Welcome to the Turd Nerds. We are the functional gastroenterology podcast discussing all things poop. Before we take the plunge into today's episode, let us tell you a bit about ourselves. I'm Dr. Rebecca Sand, a naturopathic physician and acupuncturist, and I specialize in all things gastroenterology, hormones, and fertility.
I'm Dr. Ami Kapadia, and I'm a medical doctor trained in family medicine and functional medicine with a special interest in gastrointestinal health, food and environmental allergies, and autoimmune disease.
And I'm Dr. Ilana Gurvich, a naturopathic physician and acupuncturist who is board certified in naturopathic gastroenterology. I specialize in inflammatory bowel disease, IBS, and other functional digestive disorders. Let's jump into today's episode.
The following discussion is for educational purposes only and not intended to diagnose or treat any diseases or conditions. Please consult your doctor before incorporating any of this information into your care. The information presented on this podcast is not medical advice.
All right, everyone. So we have another fascinating topic today that we have all kinds of questions about. Dr. Sand is going to lead us on a discussion on endometriosis. You ready, Dr. Sand?
Yeah, I'm so ready.
All
I have
right.
so much information to share with everyone today about this. This is a condition that I care a whole lot about because it affects quite a few people. 1 in 10 people with a uterus, actually.
That's a lot more than I would have
thought. A lot more, yeah. And reasonable because a lot of people don't get diagnosed. So
because diagnosis is nearly
challenging.
impossible, right?
Well,
without doing surgical exploration.
Yeah, we have some options here.
Okay.
Wait. So my first question is, why are we talking about the uterus?
Great
We're a GI
question.
podcast.
There's no connection, right?
None.
We're just completely changing.
We have to break down. I mean, we have to only talk about one organ
the
system.
Uterus nerds. No. So, okay, so I'm gonna talk a lot about endometriosis and things we need to know about managing this condition for folks. But spoiler, before I get ahead of myself too much, this has a lot to do with the microbiome.
What?
One of my favorite topics. So just a couple key tidbits here, so I don't lose the audience. The microbiome actually influences endometriosis pathogenesis. That's why we care. So via inflammation, dysregulation of the immune system. In turn, though, endometriosis can make the environment of your gut less favorable to good bacteria, more favorable to bad bacteria, and that's via immune modulation as well.
So can I just start with like a case?
Sure.
Okay, so I had a patient, very, very complicated patient. She had a lot of really, really chronic GI stuff. And we treated her GI, and we treated her GI, and we treated her GI, and she was patient. We kept going. After about 2-3 years of just treating her GI, she went and she got an endo diagnosis.
Yeah.
And she actually had endo surgery. And there was so much endometriosis that was adhesing her intestine to her intestine and her uterus.
Yep.
And I kept on being like, it's GI, nausea, vomiting, diarrhea, blah, blah. It wasn't.
I had
endo.
a very similar patient case, and yes, it took 2 to 3 years. The patient themselves referred themselves to, because I didn't think of it. And now
we forget about it.
Right, because it seems like it's GI, but it's not always. And she had the same sort of workup, evaluation, surgical intervention, and it did significantly help than...
It's not just the adhesions. It actually, the endometriosis inflammatory cytokines actually affect leaky gut and motility themselves. So for a couple reasons, this is probably going to affect the guts of people with endo. And they get bloated, they get pelvic pain, they get bowel pain, they get blood in their bowel movements, like all stuff that we would think like, wow, that's a gut issue.
And for some reason, thought it would be more cyclical if it was related to the endometriosis, but I don't think that it always is.
Is it cyclical?
The symptoms are all over the place. So we'll go through that here in a second. Okay, so what is endometriosis?
I'm going to try.
Okay.
I think that endometriosis is when you have endometrial tissue someplace besides the uterus.
That's exactly.
Is that it?
Exactly.
Ka-ching!
So the fancy words are an ectopic occurrence of endometrial tissue. That's all it is.
And adenomyosis, which is related, is when it's in the actual wall, correct?
Yep.
Wait. So you can have endometriosis and adenoma. I always thought adenomyosis was a fibroid.
Well, so it's the tissue.
No.
It's the tissue layer you're talking about.
The location.
So endometrial tissue traveling to other areas is endometriosis, but you can have different tissue layers affected.
So
of the uterus.
From what I remember, adenomyosis I think is specific to a particular location inside the muscular wall.
Correct.
And endometriosis is kind of, I don't think it's both. I think it's like
I see.
Or depending on the location of the endometrial tissue.
Got it.
Okay, let's dive into some stats here. So prevalence, we already talked about. 1 in 10 reproductive age biological females.
That's insane.
Yep.
Also, I just want to say, I do view you as the stat queen, if we're going to be honest.
I love that.
Yeah.
Thank you.
Yeah, thank you.
Lada. I'm working. Okay, so it's underdiagnosed due to asymptomatic individuals, so those exist.
Okay.
Comorbidities clouding the full diagnosis. So let's think of a few. Crohn's,
IBS.
IBS, urogenital disorders,
PCOS.
Painful periods. We just write them off.
Primary
Take some birth
dysmenorrhea,
control. Yeah. We could talk about that all day. So peak prevalence of endometriosis occurs ages 25 to 35. But it can exist in females who haven't had their first period yet.
Do we think it's that age mainly because that's when women are in their reproductive years? And so they're actually looking?
Right, because it's estrogen.
Yeah.
Estrogen dominance, and we'll talk a little bit about what that actually means. Estrogen fuels endometrial growth.
Yeah.
And actually, kind of spoiler alert for some other things, you need a serum estrogen above 50 to spur growth.
Oh, of endometrial tissue.
One target of treatment is actually bringing serum estrogen levels down below 50.
And you're talking about estradiol levels.
Correct. Yep.
Okay.
Yep. So other things that can cause this or make it worse, folks with pelvic inflammatory disease history are 3 times more likely to get endometriosis. So think
PID
about
history?
Yep. Think about pathogenesis there, like what's going on.
Can I ask a quick question?
Yeah.
So would this be our standard estradiol level check on day 3? That
was my question too.
Yeah.
If they have regular cycles?
Yeah. Yeah.
Okay.
That's my understanding.
That would be a great sort of puzzle piece to help with the since it's so hard to diagnose, if it was above 50.
Yeah. Other things, C-section scars and previous D&Cs.
Oh, so anytime
scarring.
you're in there messing up with the uterus, you're likely to transplant some endometrial tissue where it's not supposed to be.
Potentially transplant, potentially like adjust the environment to favor endometrial growth. But yeah, those are things. Scarring. I think there's also an argument for inflammation and microbial.
And we give antibiotics. We give
Exactly.
a ton of antibiotics for PID.
Yep.
We give antibiotics usually if there's a C-section.
But again, a spoiler here: antibiotics may be an actually good treatment for endometriosis.
Oh, that is a spoiler, because that one I didn't see coming.
Yeah.
But you got to be selective about which ones. So, okay, workup. Let's talk about this. We have mentioned it's difficult. So, actually, what's preferred now is a presumptive clinical diagnosis.
Oh.
And that's not gold standard. That's not an actual diagnosis, but this is preferred for patients without endometriomas on ultrasound. So if you happen to see an endometrioma, which will generally come back as a complex hemorrhagic or chocolate cyst, that's coagulated blood.
Okay, how often do we see them? Do you have any idea? Like, out of all of the pelvic ultrasounds that we do, are they like 5? We find them 5%?
Well, I don't know that I can answer that because I'm sending people to...
Right, pretest probability is high.
Yeah, like to a radiologist who kind of specializes in female anatomy to see. So I do get them back.
So you're getting a transvaginal ultrasound.
Yep.
And an abdominal ultrasound?
No, I'm just doing transvaginal because it's for like dysmenorrhea or menorrhagia, things like that.
Okay.
I will say, when I talk to said specialized female radiologist who I love, I think her stock imaging for any pelvic issues is always both.
Yeah.
A transvaginal and an abdominal. That's her preference.
I would say a lot of them come into me with they had it done at Epic, and when that radiologist that we're all talking about here, she'll say suggestive of endometriosis or something like that, but these come in saying it's just a complex cyst, there's nothing
the
to worry
usual
about.
Reading, I think, so which would be one more reason to send it to our particular radiologist.
But that should be, if you see an ultrasound with that kind of labeling, you should be suspicious.
Can you say that one more time? Chocolate cyst or
chocolate complex or hemorrhagic cyst.
Also, take home, find a female specialized radiologist where you live, because they're not
common?
the same. I mean, I think that
I feel
my
like
guess
Portland
is
the first place that I've heard of this type of...
No, my cousin happens to be a breast radiologist.
Oh, right.
Yeah.
I know what you're saying. Yeah, there's radiologists that do mostly mammography.
And there's radiologists that do mainly women's health.
Right.
It's really just like what their eyes are trained to see.
Right.
You know, what they're looking at day in and day out.
Yeah.
Someone who's looking at every bit of anatomy may not read it the same.
Yeah.
So,
and some are willing to give us more clinical help than others.
Yeah. Totally.
Yeah.
Yeah. So the reason this is preferred is because if the patient is like low on the symptom scale, we pretty much just start people on hormonal contraceptives or progestins. so you're not going to need a big surgery for that. If they're more severe, that's when you're going to do an MRI or laparoscopy.
And then again, MRIs might find it, but they also might miss it.
Definitely. They're going to get deeper than an ultrasound, so other tissues, like the abdomen, peritoneal cavity, things like that. But you can't treat with an MRI. Laparoscopy, the benefit is you can go in and excise lesions.
Okay.
So.
And are you going to get into symptoms?
Sure. Yeah. They're all over the place, like I said, but things that I see commonly, I'll talk about in a second. So common pelvic sites. Where we tend to see these. So ovary and ovarian fossa is 67 and 32% respectively.
Wait, ovarian fossa and what?
And the ovary.
Okay.
So it's often on the ovary. 67% of endometriosis is on the ovary. Both ovaries are involved in 1/3 of cases.
Oh, okay. Wow.
So potential fertility issues.
Exactly.
Yeah.
Yeah. Not only because of, again, the pulling, but compromised ovarian function.
Yeah.
But also it releases a lot of inflammatory cytokines.
Oh, yeah.
That are going to inhibit the egg actually reaching the tubes.
Oh, wow.
And then scarring
Which
of the
is why
tubes.
these women have a much harder time getting
Exactly.
pregnant.
Many reasons, but yes. Yep. And their hormones are thrown off. So we got all the ligaments, posterior broad ligaments, uterosacral ligaments, the rectovaginal pouch that we call the pouch of Douglas, named after some old white dude, I'm sure. Bladder is 21%.
Oh.
Things that are relevant for our audience, sigmoid colon and appendix are pretty big, but we also
outside or inside? Inside the sigmoid colon, inside the appendix?
I mean, outside probably first.
Yeah.
But there are cases of it causing bleeding, so it's going somewhere. And then it can be found on past surgical sites and in the thoracic cavity. So lungs, diaphragm, spleen, gallbladder, liver, pancreas.
I went to school with a
anywhere.
woman who had endometriosis in her lungs.
Yeah.
And she would cough blood during her cycle.
Totally.
Wow.
In the brain.
Yeah. Oh, wow.
I've seen nosebleeds around a period.
Whoa.
Yeah.
Okay.
Weird. I describe it to my patients as like a weird alien tissue that is just traveling.
I'm sure that really brings them comfort.
I mean, it is weird, and we need to learn what the alien's going to respond to. That's kind of the basis of treatment. So, symptoms.
Okay.
Again.
And then I also am curious if there has been research on regression that you've looked into. Just did a quick Google search so we could get to that in the next episode. Nice. But in our world, of course, I'm always wondering like what else can we do?
Yeah.
But anyway, I'm jumping ahead. I'm jumping ahead of
What do you mean?
Jumping ahead
regression?
of myself. Regression of endometriosis, like without surgically removing it.
Oh.
Yeah.
There's a lot. So the basis, we're kind of jumping ahead of ourselves here, but the basis of treatment is to stop feeding the growth.
Okay, which is estrogen. In part.
Estrogen feeds endometrial tissue. So that's sort of the most fundamental basis of it, and that's why giving people birth control pills, convincing their body they're quasi-pregnant, suppresses growth.
Even though there's some low-dose estrogen in there.
Correct. Yeah, because they're not going to be doing the monthly cycles.
Yeah, so you've cut way back on estrogen. Yep. I mean, there's a couple animal studies came up. We'll get to it when we get to it, but I'm curious about other avenues as well.
Yes, including the microbiome.
Right.
It's kind of like what Hippocrates said. It all starts in the gut.
Yep.
We've said it before.
Yeah. This is our motto at the Turd Nerds.
Okay, so symptoms, period pain, often worse and longer duration than your average person.
Yep.
Rectal bleeding and pain, constipation, diarrhea with menses, bowel cramping, like it's swollen, it's angry.
Basically, it can look like IBS, it sounds
totally.
Like. Yeah.
Especially,
or IBD. Right.
Like,
with blood.
Quote, period poops.
Yeah.
A lot of people come and talk about that.
I mean, everybody.
Yeah.
They often say they have more constipation or diarrhea around their cycle.
Yep. Which is also common for other reasons, right? Like
and there also is the estrobolone. Like, we should not forget about the estrobolone.
Yes, and the position of the uterus. If the uterus, gets about double in size and is leaning against your colon, you might get backed up.
Yep.
So, the amount of endometriosis you have does not correlate with the amount of pain.
Oh, yeah.
So keep that in mind. That severity, there's no link there. So some stuff that I see, my endometriosis patients, a lot of them, NSAIDs don't work. Like, I've had people who need opioids.
Yeah, because they're not strong enough.
Yeah, period pain. Bloating, abdominal guarding. So on physical exam, I feel like a lot of tension. It's sort of like a unique amount
While
of
they're
tension.
on their periods or just in general?
All the time. Because I'm doing Maya and visceral on folks, and especially their lower abdomen is, like, incredibly tight.
Yeah.
So that's something I look for. I also see it around the umbilicus, and you can get endo on your ileocecal valve, which just is a huge problem for so many reasons. So those are the symptoms I mainly see.
I wonder, because I'm just the ileocecal valve, most Crohn's disease, 85% of Crohn's disease is located right above in the terminal ileum.
Yeah.
I'm just wondering what the overlay is. I don't know.
Well, also an appendectomy.
Yeah. Yeah, I mean, there's like a huge overlay.
Yeah.
Which is why we're talking about it.
What percentage of Crohn's is in the terminal?
85% of Crohn's patients have disease in their terminal
That's a good
ileum.
stat.
Yeah.
Yeah. Okay.
Yeah.
Well, a lot going on there.
Yeah.
Okay. What do you think are the causes? The causes of getting endometriosis and the causes of endometriosis spreading.
So
Any ideas?
definitely being a born female.
Yeah. Having a uterus.
For whatever reason, having more estrogen than would be ideal.
Yeah.
Whether that's external estrogen
Prolonged
sources.
exposure to estrogen. Yeah. So early menses, late menopause.
And I wonder about the hormone mimickers, if that contributes
Like the
at all.
xenoestrogens.
Xenoestrogens
aren't helping anybody.
Yeah.
Is there any data on that?
I'm not sure.
Yeah.
I imagine there is, but
So everyone
I don't know
should
off the top of my
bring
head.
glass containers like me to put their leftovers in from restaurants.
Exactly.
I will say I definitely have a fear of plastics and non-filtered water,
Yeah.
but I do think you take it to the next level. It's almost impressive to me.
agree.
Like you have to have an
I agree.
organizational sense to be that prepared.
You could just keep it in your car, like an extra glass container.
It's impressive. It's impressive on me.
thank
I'm
you.
going to say
It's like
That's
one
a good
step
way
too
to-
far for me, but brilliant.
I
idea.
wish I could do
One
it.
of I remember my brother's wife was like, I cannot live like you. She was overwhelmed when I told her about deodorant. She's like, how can you live like this?
Yes. You'll probably outlive us all.
I do have concerns that my daughter is 10 and she has virtually never been exposed to plastic anything. I'm like, she might never go through puberty. If there's no xenoestrogens to put her through, how do we get to puberty?
Amazing. Okay, so main cause that we think, or the thing that has been dominating our thoughts here, is retrograde flow of menses.
What does that mean? Retrograde flow of
So
menses.
that's basically when the blood and the tissue in our period actually goes back up. So it's supposed to flow out, but it can go back up.
Because you're standing on your head?
Exactly. Yeah. No, it's just, so I do have stats on this. So 90% of women experience this, which
shit.
also means we can't fully explain endometriosis, because if 90% of menstruating bodies do this,
Yeah, it's not.
And
it's not a
10% of
correlation.
women have endo, yeah.
Exactly. So basically it'll flow back into the peritoneal cavity.
Wow.
But it is a way it can seed, right? So in 10% of women, the immune cells are unable to clear all the endometrial cells. So they will go back. Our immune system will identify it as foreign, take care of it. 10% of folks, that's not the case, which will then adhere and proliferate into lesions.
So I do wonder about the whole autophagy. Is that the right way to say that word?
Yeah, programmed
Okay.
cell death.
Yes. I wonder, we talk about that with sort of like the whole Dr. Bredesen Alzheimer's prevention, how you want to fast overnight and have 3 hours before bedtime without eating, just to help with some of those cycles. And I wonder about that as being just a little piece of
why not?
puzzle.
Okay.
Yeah.
Has endometriosis diagnosis increased in the last 2 decades?
I'm sure.
Because we're better at diagnosing, or because we have more toxicity? Because that's where the autophagy comes in. You know what I mean?
I mean, both.
Yeah.
Both.
Okay.
Yeah.
And then you were saying other causes. You did so.
Yeah, I have a whole list here. We're on 1 of 7.
So surgical interventions, where you were saying, because potential causes of seeding.
Yeah, and we have to differentiate between the causes of onset and the cause of proliferation.
Okay.
'Cause
What are
they're
we doing now?
different.
what are we doing now?
Both.
Okay. So
don't know
retroflow, retro.
Genetic is another one. So they
Okay.
estimate 51% are due to genetics.
Wow.
Family history makes you 7 times more likely.
Wow, that is no
So,
joke.
Ask family history. Environmental is another one, like we talked about. The big ones that we have links for are heavy metal toxicity, PCBs, and
There's actually
dioxins.
data on that.
Yeah.
Okay.
I was going to say that as a joke because as
But
a
it's the
naturopath,
estrogen
I believe
piece.
that everything is linked to parasites, protozoa, heavy metal toxicity, and mold.
I'm wondering about the heavy metal toxicity data.
Yeah.
If you have info on that.
I don't have it in
Okay,
front of me
we
right
can follow
now,
up.
and I don't know that it's a direct link
Okay.
or the estrogen, disruptor thing.
Yep. Be curious. We can look into it
It's
more.
a really good question. Yeah. So estrogen dominance is another one. Endometrial tissue is estrogen dominant, and then it's that over 50 serum estradiol is needed to grow endometrial tissue.
or any uterine tissue.
Right. Well, yeah.
Yeah.
So, that's important.
significant, yeah.
And then the causes are early menarche, late menopause, and shorter cycles, so under 27-day cycles.
Oh, that's intense.
You're being exposed more often.
Okay.
Yeah. Stress actually worsens endometriosis. We know that. We do have studies on that. Also, endometrial tissue has receptors for glucocorticoids.
Oh.
Weird alien.
So
That's what I'm saying.
like if you have stress, increased cortisol,
Yep.
Or take glucocorticoid steroids.
Yeah.
prednisone,
For things
long-term
like
prednisone.
IBD.
Yep. That was my question.
Yeah. So that's a problem.
Wow.
So basically, if you have endometriosis, don't be stressed.
Oh, yeah, because you're not stressed by the
Don't worry
yeah.
about it. Don't worry about it. Yeah. Inflammation is number 6 here. So several autoimmune markers have been identified in early disease. And we've got elevation of inflammatory cytokines, lymphocytes, prostaglandins. We also see decreased T cell activity, NK cell cytotoxicity, which is ultimately helping the endometrial tissue plant in different areas.
Because you have the immune system not taking care of it as foreign.
So
It
the
hijacks
sort of the same
system.
immune modulation imbalance that we see in like people with increased allergies and the whole Th1 and Th2.
Some overlap to cancer too. Like how
Yeah.
things
I
spread.
mean, for me, that actually does make sense. Like, we know that 90% of women, I just learned that 90% of women have retrograde menses,
Yeah.
and then it's viewed as foreign because it's
Yep.
getting into the peritoneal cavity,
Yep.
but the immune system's not there to turn it off.
Well, in most cases it is.
Yeah, for endo patients.
It eats it up,
Right.
you know.
Right. So I wonder what the statistics are on the number of people who actually have endometrial tissue that just gets taken care of. Does
I don't
anyone
even
not
know.
have endometrial tissue? Like
Here's what we know.
We
10%
would need to
of women
diagnose
have
people better.
endometriosis.
right.
Yeah. Okay, so some interesting facts on this inflammation piece. They gave vitamin E and vitamin C to folks, and it reduced chronic pelvic pain in women with endometriosis. It also decreased inflammatory markers, just antioxidants.
Okay.
Wow.
So that's cool.
You know what's interesting? When I think about my dysmenorrhea patients, I'm not thinking about vitamin C or vitamin E.
Yeah.
I might be missing something for those patients.
So antioxidants to help the immune system, potentially helpful. There's another study on antioxidant supplementation orally that reduced endometriosis pelvic pain. So these were human studies.
Oh, same antioxidants, like small, like 15 people studies?
I don't know the size.
Okay.
Yeah, I don't know the size.
Because when I'm thinking about
pretty low risk, right?
Yeah, I mean, totally, except for financial and then the diarrhea.
Yeah, although blueberries.
For vitamin C, you mean?
Antioxidants.
Antioxidants in general. Right, and resveratrol, I think one of the animal studies might have been on that. So.
Brilliant.
When I'm thinking about dysmenorrhea with my female patients, I'm thinking about ginger. Because ginger has phenomenal studies for dysmenorrhea.
Yep.
So I'm wondering if that should be part of our endo protocol.
Yeah.
I feel like I'm building an endo protocol as we sit.
We can talk about, yeah. Okay, treatment strategies here.
Okay, so
We still.
treatment strategy. It makes sense to dive into treatment strategies.
Well, let's talk a little bit about, because I have a list of 7 here too.
I think,
so
let's
we'll
get
kind of get
started.
through that. And number 7 is going to be the microbiome, and that might be a whole other episode we talk about.
Let's see what we get through.
Okay, so first line treatment: combined hormonal contraceptives or progestin only hormones.
So
Okay.
IUD
Sure.
or some kind of
Oral.
OCPs.
Yep.
So any of that, the hormonal IUDs, obviously.
Yeah.
And for like primary care providers or non-gynecologists, we do this for 3 months. If no improvement, you refer to hopefully an endo-literate gynecologist.
Huh. Interesting. I did not
To
know that.
determine if they need
that's
surgical
the only
intervention.
treatment you have, we as naturopaths and naturopath adjacent, we have a lot of options we can kind of build in here.
But you're saying that would be the next step, because then they would consider surgical intervention in the
Usually,
standard model.
well, no, because there are other drug classes,
Okay.
gonadotropin releasing hormone agonists like
Got it.
Lupron.
I was wondering about that. That's brutal. Lupron is brutal.
Yep, but it's hypoestrogenic.
Yeah, because it turns off all their hormones
Yep.
and then they go through menopause.
Yep. But is it better than surgery?
I don't know, because then what's the bone risk?
Yeah.
Right.
I mean,
and
I think
how
it's
long do you have to
nuanced.
give it? Yeah.
We also have GnRH antagonists. So Oralisa is one that
What I don't know
I've
what
had
that is.
people come in on. I knew you were going to ask that. So it's a gonadotropin releasing hormone antagonist medication that is used often for fibroids, heavy menstrual bleeding, things like that. So it's actually doing the opposite, but helps with especially the bleeding growth aspect.
Interesting.
Yeah, so I wonder about someone who's maybe closer to menopause, where you're just sort of facilitating some of this, and maybe if there isn't significant bone density effects. I obviously don't know enough to prescribe either of those.
Yeah,
drugs.
I don't give them. I don't give them, but people do give them out there. So
Okay.
I would refer for those. So we have a lot we can try besides those drugs.
Okay.
And these play nicely with birth control. But one thing I really want to do a pitch for is pelvic congestion moving the pelvis.
Huh.
So we have studies on things like stationary biking, which Alana, you also talk about for bowels.
Yeah.
So
exercise
or
is
any
amazing.
exercise or biking
Yeah.
where you're
so
moving.
getting things moving, especially if we're talking about like an immune mediated process here, get things moving.
How about orgasms?
Sure.
I mean, like, literally, if we're talking about pelvic congestion,
Yeah.
like, orgasms is literally causing waves within the pelvis, within the
I'm not
uterus.
going to say no to that one.
I do think we should think about it therapeutically.
Yeah. Yeah. Why not? I say
Yeah.
go for it. Other things on this list of moving the pelvis: contrast sitz baths.
Oh, yeah, so simple.
Cool
Hot and
option.
cold.
And I will say,
Hot
cold
cold water.
immersion is having a moment with me
man.
and lots of
Yeah.
other people, but not you guys. But yeah, so that's a great. Yeah.
Yep. My abdominal therapy, obviously, shout out for that. Pelvic floor PT, and then Chinese herbs.
Like steams, like vaginal steams, or just like herbs?
Both.
Like,
Are you
don't
going
do
to talk
vaginal
about
steams
some of
too
the
often.
oral botanicals?
Totally.
Okay.
Yeah, we can absolutely do
Okay.
that. So those are big ones. Balancing excess estrogen to progesterone.
Okay.
So we have certain supplements we
okay,
like for
wait,
that.
let's talk about lifestyle stuff first.
Sure.
One, getting rid of all the plastics, not warming stuff up into plastics, not drinking out of plastics,
Yep.
trying to keep things in stainless steel,
Remove the offenders.
right? Or glass or silicone. What do we think about silicone?
I think it's generally better than some of the other alternatives, like plastics,
Yeah.
I can't say I'm fully versed on sort of like the baking sheets and such.
Yeah, I have
Yeah.
no idea. I imagine it's better.
I think it's better than
It's
the
more
other
stable at high
alternatives.
heat.
Yeah.
Yeah.
Yeah. Okay, so what other ways that should we think? Oh, making sure your organs of elimination are functioning, making
Yep,
sure you're
that's
moving your
exercise.
bowels,
Yep.
extra sweating, urination, drinking
Yep.
enough water.
Yeah, so estrogen leaves through the bowels, right? So liver function is going to be huge for the detox
Yep.
pathways, and then getting it out through the bowels. So fiber.
And so, yeah, and I've gone back to just food-based fibers just to kind of reduce the number of supplement things we're recommending
Yeah.
for people. So just the stuff we've talked about.
Yeah, chia, flax,
oat bran,
oat bran.
all of
Totally.
those things. So,
Yeah, it's good stuff.
yep.
And then I also have on a treatment list for just basics getting established with an endo-literate gynecologist.
Is there a specialty?
In gynecology?
Yeah.
I don't know. I mean, I know people who advertise they have good training and they do good work, but I don't know.
Like, I know there's reproductive endocrinologists.
Yep.
But I wonder if there is like a...
Yeah.
I feel like the specialists our patients have sought out on their own are the ones who do the surgical procedure.
Yeah.
There's definitely specialists for that, I think.
For
you
sure.
know?
Yeah, for sure. And I think people who see this regularly,
Right.
is really what I'm looking for.
To give them a
and-
good sense of if they think that's what's causing their symptoms or not, because
Yeah.
it mimics so many other things.
and have other options besides OCPs.
the
Yeah.
meds. Yeah, the other medications you discussed.
Okay, and then the last one on this list is address the microbiome.
This may be a good place to take a break and sort of summarize what we talked about,
Sure.
and then we'll take a deeper dive into botanicals and microbiome interventions.
Yeah, so in this next episode, I'll talk a lot about why we need to care about the microbiome, studies on this that are coming out so rapidly, so cool, and then treatments that involve microbiome as well as herbal therapies that I usually give for endometriosis.
Okay, so let me do a recap.
Okay.
So my recap out of this is 1 in 10 women are diagnosed with endo. They're primarily diagnosed between 25 and 35, which is peak reproductive years. There seems to be a subset of things that cause it, including genetics, including retro flow of menstrual blood, which happens to 90% of women,
Yep.
including toxins like heavy metals, like maybe molds, but I don't think you said that. I think I made
I mean,
that up.
why not? That
Yeah.
probably should be on the list.
Xenoestrogen.
Including immune deficiencies. And then it's missed a lot because there's a lot of comorbidities.
Yeah, and I think if someone already has an inflammatory condition, like...
And it can present in so many different ways.
Yep.
It can present with primarily gut symptoms. It can present with changes in the cycle, pain
Yep.
with the cycle. So it can be kind of GI or GU related symptoms
Totally.
primarily,
Yep.
which makes it harder to diagnose. And then we can get a day 3 estradiol level if it's
Yep.
above 50. That may help give us some backing behind our theory that that's a piece of what's going
a
on,
treatment strategy.
and a transvaginal and transabdominal ultrasound.
Yeah.
So
So that would be kind of a
which is going to
starting
show
point. Either a complex chocolate or don't tell me.
I know, I think.
Oh man, hemorrhagic cyst.
Way to go on me. Full out.
If our friendly radiologist doesn't point it out for us, and we
Yep.
have to interpret it ourselves.
Yep.
All
Awesome.
right.
Yeah. So, and last thing I'll say here is it's people with uteruses of reproductive age.
Okay.
I also have seen it in folks who've had uteruses resected. they
Oh, that's
still have
intense.
growing.
They have
endometrial
extra
lesions.
uterine endometrial tissue, which
Yep.
I learned about that can actually start to grow once you put someone on HRT, apparently.
Yeah.
If they have a history of endometriosis.
Or they're still cycling.
Yep.
And there are women with endo who are asymptomatic, which is something that I learned.
Yeah.
Yeah.
So
Okay.
Great. That was great. I
Okay.
learned a lot, actually.
All right.
And we're not even done.
We're not even. We're barely
We're
getting
barely
started.
getting started.
Stay tuned.
Thanks, guys. See you guys in 2 weeks. Bye. Thanks for joining us today. Stay tuned. We release episodes every 2 weeks.
If you like this episode, please subscribe and don't forget to rate and review us to help spread the turd nerd word.